Welcome back, where we continue to talk about antihypertensive therapy using a Western pharmaceutical approach. We saw it was very important that the client does actually access integrative medicine and is getting assistance from a natural healer at addressing various very important lifestyle issues, risk factors that contribute to your risk of cardiovascular disease. But with the Western pharmacy approaches that diuretics were useful at targeting hypertension, they often might be used alone, but we saw that they often need to be used as an adjunct, where the adjunct was a second diuretic, but a potassium-sparing diuretic, to block the adverse effects of the other diuretic. Now we'll look at some other therapies which are often used in combination with the diuretics at treating hypertension. We'll also look at other drugs acting at cardiovascular disease, either angina, and perhaps we'll also look at arrhythmias, and we've looked briefly already at the treatment for congestive cardiac failure, often involving diuretics to treat the edema. One site where the edema occurred in the lungs, hence why it's called congestive cardiac failure. And so we'll continue to look at other drugs that are used in congestive cardiac failure and those that are contraindicated. First of all, we'll look at beta blockers, where they have their antihypertensive effect because they block at the adrenoreceptors that use the neurotransmitter noradrenaline or the hormone adrenaline, and in the CNS we'll see that they might also have actions against dopamine. This is a blockade. These are antagonists and they're often competitive. We talk about selective blockade at adrenoreceptors, and what we want is a drug that would be selective at the beta-1 receptor on the heart cells, but we'll see that some of them do have actions against beta-2 receptors as well. This explains their adverse effects, and because these beta-2 receptors, as you would have revised and would now understand, are on the airways in the lungs. But because of the actions at beta-1 receptors, there will be a decreased rate, a decreased conduction velocity through the heart, and then much reduced contractility of those myocardial cells, and therefore you can appreciate that all of that will contribute to a lower cardiac output, and this will then have that beneficial effect, reducing the blood pressure. Oftentimes though, if you decrease cardiac output, the body can, as a reflex, a compensatory mechanism, respond by increasing peripheral vascular resistance. So for some reason, proposed to be perhaps a CNS effect, beta blockers don't cause that reflex increase in peripheral resistance. It might be that they work at the vasomotor center in the brain to reduce sympathetic outflows to those peripheral blood vessels, or it might be that there is an observed finding, reduced renin release by the kidney with the use of beta blockers, and it might be because of this that you're also affecting the renin, angiotensin, aldosterone system, producing less active aldosterone release and less aldosterone action at those collecting ducts in the nephron of the kidney. Now we'll look at some beta blockers that are used in other cardiac disorders. We'll look at sotalol that can be used in tachyarrhythmias. Note most of the beta blockers end in OLOL, such as atenolol, which tends to be quite cardioselective for beta-1 receptors. Sotalol is also quite selective at beta-1 blockade, but it doesn't then induce excessive arrhythmias, and because it reduces conduction velocity, can actually be used to treat tachyarrhythmias. Some other indications then for beta blockers: hypertension, we'll look at that as one of the major indications, but we'll also look at them again when we look at angina. In Fallot's tetralogy, we have a congenital defect. They may be used in babies who may then be facing surgery or other options to help repair congenital defects in the heart. There are some disorders where beta blockade is simply to block symptoms. So in anxiety, hypothyroidism, or pheochromocytoma, in this tumour you produce excessive adrenaline, so the person will get tremors, tachycardia, excess sweating and so on. And so these beta blockers just simply block those symptoms at the appropriate receptors. Some other areas where we might use beta blockers prophylactically after the person has had a myocardial infarct. They do reduce the cardiac output, and so for the person this can assist then at reducing the risk of another myocardial infarct. But also vascular headaches, they do have actions at adrenoreceptors on blood vessels, and they have actions at beta receptors in smooth muscle in the eye, and so can be used at treating glaucoma, helping to reduce intraocular pressure. In terms of their efficacy, particularly for hypertension, quite good as first or second line defences at blocking high blood pressure. Some people have refractory hypertension, where then other agents or other surgical options and so on might be investigated. Beta blockers contraindicated in a person with congestive cardiac failure. We'll see there's only one drug that is indicated, one beta blocker that can be used in CCF, where it then doesn't induce arrhythmias and other events in the person's heart, which is now failing due to other disorders, age and so on. Beta blockers also contraindicated in chronic obstructive pulmonary disease. These drugs are selective for the beta-1 receptor, that's how they have been designed, but they may have adverse effects on the beta-2 receptors in the airways, and so for a person whose airways are fibrotic and quite distended, then any actions that might contribute to constricting them are to be avoided. And you may have seen from your research that there are other beta receptors in the body controlling lipid metabolism, and beta blockers are contraindicated in diabetes. They will have effects not only at blood vessels, which are becoming damaged, but metabolic actions as well. So it's atenolol, another one of these cardioselective beta blockers targeting beta-1 receptors, where you get less of all of these adverse drug reactions, but still that's not the one indicated in congestive cardiac failure. The one that is the first line treatment as a beta blocker if a person had that congestive cardiac failure would be carvedilol, and so we've indicated that in the name. It ends in the LOL, giving you a clue that it's a beta blocker, but the CAR telling you that it's the one used in cardiovascular congestive failure, so cardiac or heart failure. ACE inhibitors are also used as antihypertensives. We'll also look at some of their other uses and their adverse effects. Once again, they have a common generic ending. They are the PRIL drugs, the prils. So we have captopril, enalapril, and fasinapril. We've also given some common brand names there because they're quite readily recognizable, and you may already know some people on those therapies, or when you get to clinic and you are observing people taking case histories, you'll hear ACE inhibitors, and clients, as we said, commonly giving you the brand name, and you'll look them up, see that they end in this PRIL, and that will be very active as a memory trigger at helping you remember a lot of the information about these ACE inhibitors. So the one piece of information we want you to know and understand is that mode of action. We said to you that they're targeting an enzyme in the body. The enzyme is angiotensin converting enzyme. It converts angiotensin 1 to the more potent vasoconstrictor angiotensin II. And this ACE inhibitor will competitively block at that enzyme. And so here, because you are then producing less active aldosterone, active at the ducts in the nephrons, you'll get less reabsorption of sodium, affecting blood volume. This is going to affect total peripheral resistance, primarily at reducing blood pressure. But it's interesting that where a person is on one of these ACE inhibitors and they are not reabsorbing sodium, they become in somewhat of a sodium depleted state. And so in this state, the actions of the ACE inhibitors on the conversion of angiotensin I to angiotensin II are more potent, more intensified. And so oftentimes you'll see ACE inhibitors used as a combination therapy with the diuretic to put the person into that sodium depleted state where the ACE inhibitor action becomes more intense. This is a beneficial synergistic action, a pharmacodynamic interaction where you can then use the ACE inhibitor, oftentimes in lower doses, and or perhaps using the diuretic in lower doses. Also, because these ACE inhibitors work on sodium and block its reabsorption, they actually also often improve potassium retention, and this will counteract any potassium depletion that you saw was an action of loop or thiazide diuretics. So by using the ACE inhibitor with the diuretic, you now don't need the potassium sparing diuretic, because you're using this other combination therapy to target the potential hypokalemia, that adverse drug reaction of the diuretic. But unfortunately, these ACE inhibitors do then also have their own adverse drug profile, where it would be good to be able to use them in a lower dose. They produce this mechanism in the lungs where there is also less breakdown of bradykinin. ACE, being an enzyme that's part of the systemic circulation, does also break down bradykinin, particularly in the lungs. When bradykinin is more long-lasting in the lungs, it sets up an inflammatory reaction because it's one of your inflammatory mediators in the lung, and the person develops a cough. Now, this cough is not dose dependent, so many of the other adverse effects of the ACE inhibitors can be reduced by taking it in combination with the thiazide diuretic or the thiazide-like diuretic, or taking it in combination with a loop diuretic, but the cough does not respond. And so oftentimes that person has to be taken off the ACE inhibitor. It limits its use. This happens in about 1/5 of people, and women seem to be more at risk of this ACE inhibitor cough that develops. And so other therapies were then investigated and released to market. Rather than targeting the conversion of angiotensin I to angiotensin II, they didn't target that enzyme, they targeted the receptor for the angiotensin II. Drugs were then investigated that blocked that receptor. So these are the angiotensin II antagonists. And once again, as you can see, their generic names all have a common ending. These are the sartans: losartan, irbesartan, candesartan, and telmisartan. And once again, we've given you some brand names there because some of them may be familiar to you, that your family, friends, if you are already a practitioner because you have a diploma or other qualification, and so you already have clients where you've taken their case history and you know the drugs that they're on, some of these might be familiar to you. So we want you to then be able to explain in detail that mechanism of action of the angiotensin II antagonists at that receptor. There are once again many different types of angiotensin receptor, and it's particularly the angiotensin I receptor subtype where the effects of this competitive blocking are seen the greatest. And at this particular type of angiotensin receptor, you would normally mediate smooth muscle contraction. And so because you're blocking that action, you get a smooth muscle vasodilation. Also, there's an increase in salt and fluid excretion. This then also contributes to reducing the plasma volume. It's also known, though, that these angiotensin II antagonists that work at the angiotensin I subtype and competitively block there, then don't produce that cough in the lungs. That's particularly just seen with those ACE inhibitors, because that ACE enzyme was also needed to break down levels of bradykinin in the lungs, and when you inhibit that enzyme, the bradykinin levels built up. But you don't get that bradykinin response with the angiotensin II antagonists, and so for a person that might develop the ACE inhibitor cough, they might then be put on one of these sartan drugs. Now, also to treat hypertension, we might use calcium channel blockers. Go back and review the physiology, how calcium entry into the sarcoplasmic reticulum is often the mechanism by which that contraction occurs, and so if you block some of the calcium channels and less enters the cell, you'll get less of a contraction. With these calcium channel blockers, there's no chemical similarity between them. You'll see then that they have many different endings. There are some that are dihydropyridines, a particular heterocyclic ring structure, and so as their name indicates, ending in that INE, we have phalodipine, amlodipine, and once again we've given you brand names in case they help you identify particular Western pharmaceutical agents that you may already know people who are on that particular agent. Then there are others that are phenylalkylamines. They're still nitrogen containing structures, but chemically different, a different chemical class. So we have diltiazem, and we've given the brand name once again if you may know some people or clients that might already be on that therapy. Then there are others that are benzothiazepines. Once again, as you can see from the name, that they may contain other functional groups other than that nitrogen group, and so chemically a different class, a different generic ending. We have drugs like verapamil. Now, phalodipine also had other actions as well as blocking at calcium channels. In terms of why calcium channel blockers would be indicated, we're going to see them once again when we look at arrhythmias in the heart, where it's particularly verapamil. That might also be useful not only in treating hypertension but in treating arrhythmias. But the other calcium channel blockers might also be indicated in angina, but just for one particular type, the chronic stable angina, where it isn't degenerating to the point where the person might then be at a greater risk of a myocardial infarct. And then lastly, essential hypertension, one where the cause might largely be unknown. They tend to respond to calcium channel blockade. The mechanism of action is varied and requires you to review the actions of calcium ions in causing that contraction inside muscle cells. Because they block at the channel for the calcium ions, and that's a competitive blockade, that reduces the amount of calcium that will produce that excitation contraction process, that change in the polarity of the membrane of that cell. Right, this is going to relax vascular smooth muscle and in that way lead to that vasodilation that will lower blood pressure. It does also then have an effect on total peripheral resistance because it's targeting vasodilation. And so there are many calcium channel blockers from many different chemical classes, and some show more of one mechanism than another. Those dihydropyridines, so phalodipine, amlodipine, they particularly target calcium entry via that particular protein channel. But there are others that have actions on cardiac muscle cells and the entry of calcium ions into those muscles, whereas amlodipine, phalodipine targeting smooth muscle, these ones are targeting cardiac muscle, and they have this decreased inotropic effect, a decreased force of contraction from that cardiac muscle. Get a reduced length of that contraction cycle as well, and in these ways you target cardiac output and thereby lower blood pressure. But it was because of this mechanism of action that these calcium channel blocking agents that have this second action are often contraindicated in congestive cardiac failure. Then there are agents that target specifically alpha-1 adrenoreceptors, where they block those receptors. The alpha-1 receptor on systemic blood vessels tends to cause a vasoconstriction, and you're blocking this. And so you get a vasodilation effect at smooth muscles in arteries and veins of the general circulation. So we'll see that skeletal muscle is slightly different, but we're looking at targeting blood pressure, and so it's the actions on the systemic blood vessels, a vasodilatory effect that you get with prazosin and other alpha-1 adrenergic antagonists. But once again, we want you to be able to explain it in terms of peripheral resistance or cardiac output. Because we're blocking alpha receptors, you'll get an increased vasodilation, which will obviously assist to lower total peripheral resistance. But now the amount of afterload on the heart, the amount of blood that is then pumped into the arterial side for the general systemic circulation will be less, and this reduces the venous return. So then there's this flow-on secondary effect after the change in total peripheral resistance that reduces the preload and the afterload and decreases the cardiac output. So these are very good choices because of that dual action for people who were refractory to other forms of antihypertensive therapy, because they also target alpha-1 receptors on sphincters. They are good at treating urinary obstruction, which you get in benign prostatic hypertrophy. And so if a person has hypertension and BPH simply because of their age, the one drug can target both pathologies. There are some drugs, as we saw, where you treat one arm of the blood pressure equation and you get a reflex action on the other arm. So you change total peripheral resistance, but all that does is then create a compensatory effect on cardiac output. In a similar way, when you have a vasodilator, sometimes the body compensates for that by speeding up the heart and you get a reflex tachycardia. So you can see that that wouldn't be very useful if the person had an existing arrhythmia. But prazosin doesn't cause this reflex tachycardia as it causes vasodilation by its action at alpha-1 receptors. So it makes it very useful in certain clients. But there will still always be an over-exaggeration of their mechanism of action, as with any of the drugs that target the blood vessels, you might get hypotension. In this case, a postural hypotension, that orthostatic hypotension, when the person changes body position by only a small angle. They might be lying down and then sit up, or they might be sitting and they stand and then they become quite dizzy. So also, just because of the excessive exaggeration of their pharmacodynamics, the person might become incredibly dizzy after the first dose. Oftentimes they will become unresponsive to that compensatory hypotension when the person stands up, but oftentimes they need to be taken off the therapy if the dizziness or the postural hypotension continues. So in summary, we saw that there were many antihypertensives, diuretics. Often you'll see the first or second line therapy, but people can be unresponsive to them, or they may show such excessive adverse effects such as hypokalemia, not even ameliorated by the use of potassium sparing diuretics, that they might need to go on a beta blocker. ACE inhibitors were also useful as antihypertensives. If a person develops a cough, that was a dose limiting adverse effect where often the person needed to be taken off the ACE inhibitor and perhaps put on a beta blocker or an angiotensin II receptor antagonist. But the beautiful thing about ACE inhibitors, they also tended to target the hypokalemia that can occur with diuretics. They work synergistically with the diuretics, and so that was another good combination. But angiotensin II receptor antagonists didn't tend to produce the cough, and they targeted the type 1 subtype of the angiotensin II receptor. We saw calcium channel blockers also useful. They had two ways of affecting cells that are contractile when calcium ions enter into their sarcoplasmic reticulum. We saw that some of the drugs worked at smooth muscle contraction, reducing that contraction and thereby producing a vasodilatory effect, but there you could get rebound effects on the heart and tachycardias, but others that then worked at the calcium channels in heart muscle, a dual action also working at the blood vessels. And so some of them you didn't get that reflex tachycardia. You also didn't get that with certain alpha blockers such as prazosin. There were other drugs that were directly vasodilatory, hydralazine, and then don't forget clonidine and some other substances that might work centrally at various adrenoreceptors, looking at reducing sympathetic outflows and reducing hypertension in this way.